Good evening to everyone. We have Dr. Ankit Mittal, MBBS, PGDID, DM Infectious Diseases, a clinical fellow of solid organ transplant and oncology infectious diseases. Welcome, you, sir.
Thank you.
There's a short interview. I'll start with the questionnaire. We would like to know some basic and general information regarding infectious diseases as a branch, sir. Please let us know.
Okay. So this is a very important question. So a lot of people ask me this question in general. The point to note over here is that the branch is not new, as in the practice of infectious diseases is as old as medicine, the branch of medicine. It is just an extension of medicine, just like any other specialty for that matter. But the thing is, with infectious diseases, everybody, like each branch has its own patients who have their own individual or special infectious syndromes or presentations, and each branch would know how to deal with most of their patients, right? But the problem here is with specialized care. Now with time, when special population, drug resistant infections, etc., are going to increase, at that time it becomes slightly more difficult to manage these patients. So that is where a formally trained or a specialist in infectious diseases usually comes in. So it is not for the general care of all infections, right? Because almost everybody knows how to manage infections. Sometimes the practices are incorrect, and that is primarily responsible for this rising antimicrobial resistance also. And this is something that our country is lacking. Right now, say I'm practicing in Toronto, where infectious diseases is an integral part of care of all patients, right? So, and they ensure that with respect to drug choices, dosing, timely escalation, de-escalation, everything is in place. And this helps in keeping the drug resistance rates low. When your drug resistant rates are lower, the success of management or the outcomes become better. So here we have, say, 5 or 7 or 8 antibiotics to choose from. But back in India, if a patient is in the ICU, it's critically ill, you probably just have 2 or 3 antibiotics to choose from. And it is unfortunate that even then, even with that kind of high drug resistance, where uh, appropriate antimicrobial dosing choice is so important, a lot of places lack the correct practice. So that is where primarily the role of infectious diseases specialist comes in. As far as the field is concerned, say the DM in infectious diseases, that might be a new branch, only say 6, 7 years from 2016. It started in 2016 at AIIMS, but there have been fellowship programs already, right? PD Hinduja. There were other hospitals that were providing or training people in infectious diseases. CMC Vellore has a very old department in infectious diseases. So a lot of people were already working in this. It is just that in 2016, a new DM in this branch was created, but that doesn't mean that this is a new branch or something. But yes, now that more DM infectious diseases doctors are there, you can expect that things will slowly start to change. Maybe over 5 to 7 years, they will slowly start to change.
Okay. Also, please throw us some insights about life of a resident in infectious diseases as a branch.
Okay. So this is again going to be slightly different because, say, for example, I joined AIIMS New Delhi as a 6 years resident. So there I did my junior residency also and senior residency also. The life of a junior resident is very different from the life of a senior resident. Okay. And for the majority of people, it is going to be life of a senior resident because you will be joining the specialty after your MD. It is only AIIMS Delhi that is offering you a 6 years course where you will also spend 3 years of junior residency in the department. If I were to speak about my experience, so as a junior resident, you're just working like any MD medicine resident. So the working hours are as long as tedious, you know, You have to just work like an MD medicine resident. There is practically no difference except for a few rotations. So you will have some rotations in microbiology so that you get some orientation with respect to infections, right? You need to understand about infections in detail. So that is a little bit of difference. And then you will have some rotations in pediatrics, which is usually not the case for MD medicine residents. But apart from that, it's more or less the same. You'll rotate in cardiology, neurology, right? You'll do just the same work as anyone else. And in senior residency, the role changes. So it becomes more supervisory. Now, this is with respect to AIIMS only I'm talking, right? I'm not very much aware about other institutions where they only have senior residents in infectious diseases. But in AIIMS, it was more like a mixture of individual patient responsibility plus supervisory roles, doing admission day duties. Along with that, you'll have clinics, etc. So it's a mix and match of a lot of things, and yeah, that's it. But yes, it's not a very light branch. Means with respect to JR ship, it's the same, right? With respect to SR ship, it is probably not as hectic as, say, somebody who's in gastroenterology, right? Or more demanding branches like cardiology, neurology, where they already have their own inpatient, they have some interventions that they do, and they have a legacy, right? So these are well-established, long-standing branches with a large patient pool. So they obviously have much more work as compared to a senior resident in infectious diseases right now. But things would change eventually, right? When there are inpatients, as and when you start having inpatients, your work is going to increase exponentially.
Um, and so, what are the things that you love in being infectious diseases? Like,
Okay, great. So there are lots of things. So first of all, I think this is one of those specialities that remains very close to internal medicine. Now, I think the second closest could be rheumatology, right? Which would still think of multi-system disorders, try to link one thing with the other. But infectious diseases is just like internal medicine for most of its part. So you need to know about all the systems. It cannot be that you're just looking at a culture report and telling somebody about the treatment options. If you're dealing with an infection of the heart, you need to understand about the heart. If you're dealing with the infection of the CNS, you need to understand about the CNS. If it's a critically ill patient, you need to understand about ventilatory management. You need to understand about organ dysfunction, how to assess organ dysfunction, improvement or worsening, etc. Even for now, if I'm say training in transplant infectious diseases, I need to understand transplant. I need to understand the procedure, the surgical procedure that is being done, because that eventually links everything to the kind of infections that that person might develop. So that is one thing that I really love about my subject, because it remains very true to the parent subject, which is internal medicine. And the other thing is challenges. So there are a lot of difficult to treat cases, difficult to diagnose patients. They have diagnostic dilemmas where you can actually help the primary specialities, as well as they might just come into your own clinic who have been referred from a lot of places, have not achieved the diagnosis. So that is one of those aspects of the practice. And apart from that, yes, it provides a good work-life balance. So it's not as hectic as a lot of other specialities. So for me, personal time, work-life balance is very important. So that's one more thing.
okay, so you also told us about the consequences or in the department. Is there anything more to add regarding the cons of being the infectious diseases resident?
Okay, cons. Cons, I would suggest as of now. the cons would be, especially in India. So this is with respect to India. Of course, I am also going to come back to India and practice there. Is with acceptability, acceptance, right? So, like with any new branch, it's going to be a problem for a few years. So, it always takes maybe a decade or so for any new branch to, make its presence felt, especially if it's a non-interventional branch. So, infectious diseases is a non-interventional DM specialty, right? As of now, more and more people are attracted towards interventional super specialties because of a lot of things. It gives you a different kind of satisfaction. Say a gastroenterologist performing an endoscopic procedure or a cardiologist performing angioplasty, etc. So that gives an another kind of gratification, right? There's a immediate results that you see and you're directly involved. So it's very close to the role of a surgeon in a way. Right. So, of course, that is another thing which is lacking in infectious diseases. And but again, I would come back to the pros again once for this time that since this is a new specialty as a DM specialty, and that more government hospitals or corporate setups are going to absorb a lot of DM specialists, that will open a lot of gateways towards research. So, India as a country, unfortunately, despite having so many doctors, so many patients, almost every clinical condition that is described in textbooks, we don't have good research output. Most of the research are either prospective, retrospective studies, case reports, right? So we don't publish a lot of clinical trials. So that is one thing that is severely lacking, not just in infectious diseases, but practically in all fields. The way India should have a research output, it's not there. But and with DMID specialists, it will be possible to at least do some quality research in the field of infections, especially because the thing is with respect to other specialty, for example, a cancer will behave similarly in India and in America, right? For the most part of it. Uh, Myocardial infarction will behave similarly in both the countries. Stroke will behave similarly in both the countries, but infections will not. The infections epidemiology is going to be completely different in each country. So we cannot just say that if ciprofloxacin is working in United States for febrile neutropenia, it doesn't mean it is going to work in India. So we need to have local guidelines. We need to have, uh, local evidence to show that one treatment is more effective than the other, and that can happen only through research. So that will probably be one of those important areas where any practicing ID physician, especially in the government setup, should be looking at.
Please enlighten us about the type of personalities who should choose the branch of infectious medicine.
Okay, so I'm not really aware of personality types, but yes, somebody who wants to, balance your me time and work time needs to have a good family life also, is not too fond of interventions, right? Probably they can choose this, but yes, the you have to love internal medicine. So if you think internal medicine is not your cup of tea, then you should probably not consider infectious diseases.
Okay. So what are the type of personalities that should not be using, like
Okay, so it's
there
just
will be
the opposite of what
specifications?
So just the opposite of what I told you, right? So again, the other thing that I did not mention is probably the monetary aspect. So by default, interventional branches will give you more money. So there is no doubt about it that interventional branches will give you more money, but interventional branches will have a in today's date and time, especially if you're looking to settle in a tier one city, it's more difficult with the interventional branches right now because there's a lot of saturation in the setup usually. A lot of cardiologists or nephrologists or a lot of other specialists are already practicing in tier one cities. So there will be a time lag. So the time to settle will be more in these specialties. But of course, they will pay you much more later, right? All interventional branches will pay you more in general. So, so that is one thing. If you're more after money and you're okay to spend a lot of time at work, then probably interventional branches will make more sense. For infectious diseases, you need to be more satisfied with, I wouldn't say a low income, but a okay, generally good. It wouldn't be counted as a low income. It's a fairly, well balanced market out there right now. But you won't be able to buy a Mercedes S-Class with 7, 8 years of practice for sure. That's not going to happen. The other important thing is when we are talking about money, in today's date and time, it is anyway about how you manage your money. So you may earn tens of lakh rupees a month and you may still not save anything. So it's anyway up to you how you manage your money. That makes more difference in the long run rather than earning a lot and spending everything, right?
Yes, sir. Thank you. And like, how many years will it take on an average to settle down after choosing this branch?
Okay. So right now, based on like my personal experience and people that I know, so here I would like to clarify that I was first in the 6 years branch, but at that time, the 3 years course was also started. So by 2019 end, the first batch of post MD DM residents was already out, right? So I joined post MBBS in January 2016. At the same time, few people joined as post MD in the senior residency batch. So they completed their course in 3 years. So by 2019 end, we had our first batch of DM infectious diseases people, and they're doing well. So I know people who went to WHO for a year or two, right? Somebody worked in ICMR. A lot of people are working in corporate setups, and one of my seniors has started the infectious diseases department in KMC Manipal, right? And another of my like senior and a very good friend, guide, whatever you can call him, has started the department in Calcutta in IPGMER. So the opportunity is immense, and here you get the first movers advantage. Now, say for example, if there are 5 hospitals that want to start this department, and if there are only 4 specialists available, so there's already a demand supply gap right now. It's not going to be the case in future because a lot of other hospitals and colleges are coming up with the DM branch. So right now the time to settle is not very high. So as soon as you complete your DM, probably you're going to start work in a few months. Like those few months is up to you, the kind of place you want to work in. You will have that freedom to choose from. So right now, it's not that bad. Uh, Maybe some places will ask you to join the internal medicine department and work under the internal medicine department. But a lot of my seniors are working independently as an infectious diseases consultant. Some of them are working freelance, some of them are working full time. And with respect to, so there's a slight bit of geographical differences if we talk about opportunities. So I would say that the southern part of India, means Hyderabad, Maharashtra, and downwards, the opportunities are more as compared to, northern part of India. So as of now, there are lots of opportunities in southern part of India, and you can
Yeah,
start working as soon as you pass.
yeah. Considering the students now, like MBBS, they are doing it now. So over a period of time, like down the lane, 3 to 4 years later, for them, what would you think would be the time of settlement?
So that will again depend. So if you're so again, the practice is primarily based in bigger hospitals, right? Right now, the demand is more in the bigger hospitals where you want to reduce hospital-acquired infections. You want to admit patients with multiple issues. You are going to do transplants, etc. So as of now, the demand is concentrated in these hospitals. But eventually, when the practice becomes more universal, when the infectious diseases doctor becomes a part of the general care of patient, right? Then probably tier two cities will start having some demand. And then it will obviously be up to you. So, right now, the kind of role that I'm talking about in infectious diseases is that of a consultant. So, patients will primarily be admitted under different departments, and you will be providing consultation services. But say you want to admit patients under yourself as well. So even that is possible. If you want to admit patients, you can admit patients and then you can join any hospital that allows you to admit patients in the hospital, right? Especially in the private sector. Even in government sector, like I was telling you in IPGMER and KMC Manipal, they have their own inpatient for infectious diseases. So they are admitting patients, managing them. So currently they are short-staffed. They are going to remain short-staffed for quite a few years. But yes, it is true for all specialties. As and when more and more specialists are produced by the colleges, there is going to be some saturation. And then the settling time is going to increase, just like for any other specialty.
Okay, thank you, sir. Like, what we also want to know about the monetary aspects in this field, sir.
Okay, so I've already spoken about this few minutes back, but it's not bad, like it all depends on how much is enough for someone. If you think you need to earn, say, tens or fifteens of lakhs of rupees per month, so that is not going to happen. For sure, it's not going to happen. But you'll have a decent amount of income. You can have a good lifestyle. You can have a good work-life balance. So you'll have to, weigh in all of those things. If money is everything, if you want to earn a lot of money, then probably interventional branches can offer you that. But then it will always take a toll on your personal life. So that you need to balance it out, right?
Yes, sir. Um, sir, like, what about any other free time or any other activities that you want to do? Like, will there be time available while being the resident and even after?
So as
Like,
far as junior
what
residency, so as far as
you
junior
were speaking
residency is
about?
concerned, yep.
Uh, No, like you have already told about work-life balance and all. There will
Yeah.
be some free time, but like any other thing,
So it is totally up to
especially.
you. So I can tell you just from my experience, limited experience, that right now I'm in Toronto, right? So here people think very differently. In India, people used to think very differently. Here, free time is not something that is available to them. Free time is something what they create out of available hours. So it's a part of the lifestyle that they would go for a run or hit the gym, have a hobby. But what I felt back in India, probably it was limited to me, is that we wait for a holiday, we wait for a weekend to be able to do some things instead of trying to, make it a part of our daily lives. Even if you're waiting for the weekend, you'll at least have a good weekend. If you're an ID specialist, more often than not, you'll have a good weekend. And unless you decide to start admitting patients under your care. So once you start admitting patients under your care, it's the same story everywhere. But if it's not the case, then you'll have a good weekend. You'll have definitive working hours, right? Probably you will not be involved in emergency on calls. You will not have to, be up all night like a critical care physician or an emergency physician has to be. So all of that is there, but yes, you'll have some time for yourself for sure. That is for sure. So I've spoken to all my seniors, all my colleagues. So they seem kind of happy.
Okay. Like being infectious, being in infectious diseases, you said like it is generalized, or it is something which is like general medicine residents will also do or consultants will also do. So there is competition from general medicine, and you mentioned rheumatology. So with this competition, how do you think will be the future of infectious diseases as such, like growth in infectious diseases?
Good question. So the thing is, this competition is a very unhealthy competition and unnecessary competition. So right now, say if you want to compare it with places that have better practice of medicine. Better by the means, I mean more established practice, more structured practice. So if you look at Western countries or European countries, they have all these specialists, right? And they still work in harmony when the ultimate outcome is patient welfare. So it is not like this is my patient, I will take decision. How can somebody else take a decision on my patient? So that is now not how it should go about. So this whole idea of being competitive and all, I find it very unhealthy. The thing is, moreover than that, with time, what is happening is every field is getting specialized. So if a surgeon was doing X number of things 10 years back, now he or she has to do 100x things now. So there is a lot of time and energy that a particular specialist has to spend in his or her own specialization right now. So what happens is after a certain amount of time, their knowledge or information about other things. So here, what I mean to say is, say infections, a particular infection will cease to improve. So they will continue to practice the same thing that they learned few years back. Whereas the practice might have changed, the evidence might have evolved. So at that time, the role of the specialist, the other field specialist, so here the infectious diseases specialist will come in. Now, how do you compare this scenario? Say, for example, 10 years back, the practice of rheumatology for most people was steroids. Steroids, methotrexate, plus minus something here or there. But now the practice of rheumatology has evolved so much. Newer medications are available. Now, it is not possible for a general medicine practitioner to keep up with all these developments happening in the field of rheumatology when he or she also has to take care of a lot of other things in his or her own specialization, right? Earlier, medicine people would practice endocrinology also, right? They would practice neurology also. At till a certain point in time, that was correct. But later on, when things drastically changed or the knowledge available increased a lot, so it became difficult for older people to keep up with the pace of these things. So then you have to refer it to the specialist. So the same will be the case with infectious diseases. Right now, since everybody is practicing infectious diseases, everybody has knowledge about these things. 10 years from now, when there will be a lot of advancements in the field, people will not find time to keep up with all the advancements in the fields of infectious diseases unless they are very much interested in it. They will have to devote time and energy to their own specialization. So that is what I'm seeing here also in Toronto right now. So people are more concerned with their specialization. They want to excel in what they do the best. And when there is a issue with infection or a diagnosis, they will send a consultation to the infectious diseases team and they will take it over from there. Right? So that is how things work. I hope I was able to make things clear.
Yes, sir.
Okay.
Also, please throw some light about super specialization and fellowships in infectious diseases.
So the field itself is a super specialization as of now. It's a DM branch. As far as fellowship is concerned, so right now I'm doing a fellowship in Toronto General Hospital in transplant infectious diseases. You can do fellowships in, antimicrobial stewardship. in tropical medicine, and in general, you can, if you want to train further, you can go to some international center to learn about adult infectious diseases in general, right? So there are lots of opportunities. If you are, say, if you want to explore the opportunity in United States, you have a lot of opportunity in United States, but then you need to decide early because for fellowships in US, you need to crack USMLE. So you have to have a USMLE for fellowships in US. But yes, apart from that, there are lots of fellowships available. You need to decide if you want to do it or not. So for me, I thought it was a good idea to explore transplant patients because you don't have a lot of exposure in India, and slowly transplants and all are going to increase in our country. So at that time, complications associated with transplants are also going to increase. So I thought this was a good opportunity to probably learn something new.
So what are the things that should be considered for choosing a college for like for infectious diseases branch?
So right now, I would suggest patient load. So one of those things that help you learn is patient load, right? So they are the best source of knowledge. So if it's a good hospital with a lot of patients coming in, so that will be a good place. Then you can look at the faculty, right? So if they have trained faculty, good experienced faculty that can teach you, because more than, so again, this is true for all field in medicine, surgical, non-surgical, MBBS level, postgraduate level, the amount of things that you learn from a teacher is far greater than what you learn from your books. So if you have good experienced teachers who can pass on knowledge, during rounds or during clinics or whatever. So it's obviously difficult to understand this unless you enter that college. But yes, you can have some feedback from your colleagues or seniors or friends as to how the department functions and all. So that is one thing. And yes, research. So unfortunately, a lot of institutions don't promote research because of various reasons. But if you get an opportunity where you will have some research, exposure, then that should be one of those criteria. Say, for example, AIIMS Delhi provides an excellent research opportunity. A lot of other institutes encourage research, especially with youngsters. So that could be one more criteria.
Okay. And finally, is there any special message from your side for all of us who are aspiring?
I don't know. Means if I were to speak about myself, when I took this course, I was also very uncertain. It would be a lie if I tell you that I knew for sure that this is what I wanted to do. It's not like that. But right now, I'm content with what I'm doing, right? It is kind of adding some value to my life as well. I'm happy with my future prospects that I currently understand. And the other thing is, I get a lot of questions from people, especially, MBBS students like yourselves. So a lot of other students also, they are very much focused about what is the scope of the branch. So it shouldn't be like that. First of all, this is a DM branch. You need to first understand whether you want to do a clinical subject or you don't want to do a clinical subject. If you want to do a clinical subject, decide if it's to do with medicine or with surgery. If you think, yes, medicine is something that you like, then you take up MD medicine first. During your 3 years of MD medicine, you will have exposure to all the subjects, cardiology, neurology, endocrinology, right? All subjects. And then you should, worry about what should be my DM. It shouldn't happen that in MBBS years you're thinking about being a cardiologist. So there are two things. One is to aspire to be someone. So I think it is probably every MBBS student's dream to become a cardiologist one day, right? It used to happen in my time at least. So that is one thing. You aspire to be someone because from your childhood you see a cardiologist having a very flamboyant, presence, and you're very impressed. So there's nothing wrong with that. But you need to later on decide whether this is the field that you want to be in. That you cannot decide during MBBS. So MBBS is very different from real world. So even during MD, you will get a little bit of idea of how things work, and DM specialty and DM practice is completely different. So people should not expect to understand the nitty-gritty of choosing a specialization or how the practice is going to be during MBBS years at least. So focus first on uh, what subject you like, whether it's a surgical, non-surgical, clinical, non-clinical, and then do that subject, read, understand that specialty first, right? And during that time, try to make up your mind that what could serve you better, or is there even a need for a DM? There's a lot of need for uh, physicians. Right now, everybody is doing DM, or everybody wants to do a DM, but there's a huge lack of good internal medicine practitioners as well. So whether so for me, for example, if I were to be very honest, I got so my all India rank was 76 at that time, 2016. I always loved the field of medicine, MD medicine. So at my rank, I couldn't take MD medicine seat because it's usually filled by rank 10, right? And I got this opportunity of taking the DM in infectious diseases. And I got to know on the stage of counseling that this is run by the Department of Medicine and you have to work like a medicine resident. That is when I decided to take, fine, that since I have to work in the Department of Medicine, I'll take this up, right? So if I were to do only MD medicine, probably I would stop at MD medicine because I feel there is a lot of need for internal medicine guys also. What happens is if you go to a neurologist, now this is, I'm just talking in very layman terms, general, right? It doesn't mean to say that specialist guys don't know much, but the vision becomes myopic. If you go with an issue X to a specialist, he or she will consider probably differentials related to their specialty, right? They will work you up for issues related to their specialty. But the medicine guy will have an overall picture, right? And you cannot blame the specialist because that person is day in and day out working only working only in their specialty. And it might seem very funny, but with years, like say if you spend 10 years in neurology, for example, then nobody can expect you to remember things about cardiology, nephrology, endocrinology, right? But an internal medicine guy will at least have some basic idea about all the systems. So that is very important in terms of patient care also. So the first contact of the patient should be with the internal medicine person. He or she should be the person who decides that where this patient should be referred. So it shouldn't be that if somebody is having headache and you directly go to the neurologist, right? Somebody is having chest pain and you directly go to the cardiologist. So it shouldn't be like that. So if I were to, make a decision and if it were possible for me, then I would have probably stopped at MD medicine and then explored, worked for a few years, try to understand how things work, which specialty is probably more suitable for me, and maybe then again come back to infectious diseases. I would have probably again chosen infectious diseases. But yes, I think that should be the approach rather than, just trying to focus too early on the specialty, especially in MBBS time.
Thank you, sir.
Okay.
Uh, yes, sir.